Welcome to the Interventional Glaucoma podcast, brought to you by Elios Vision. Join us for unscripted discussions about the latest innovations in interventional glaucoma with leading ophthalmologists in the field.
Welcome everyone to the Interventional Glaucoma podcast, brought to you by Elios Vision. I'm your host, Cathy McCabe, and today I am thrilled to welcome back my two colleagues here. We have Mark Gallardo and Dan Lindfield, and I'm so excited. We're going to continue our conversation. As you may remember, we were talking about patient selection, preoperative conversations, just kind of that interventional mindset with MIGS devices for our cataract and glaucoma patients, and then specifically how Elios fits into that decision-making process. So thanks for joining me again. And if you would like to just briefly introduce yourself and your experience with Elios so that we can kind of remember where we're at with that. So go ahead, Dan, and tell us a little bit about yourself.
Thanks again, Cathy. It's great to be back and to see and hear you again. So I'm Dan Lindfield from the UK. I'm a cataract glaucoma MIGS surgeon. I'm about 9 months into my Elios journey and about 40 cases performed so far.
Great. Yes, excited to be here with you. And Mark, go ahead.
So I'm Mark Gallardo, glaucoma specialist out here in El Paso, Texas. I was exposed to the Elios device a little over 2 years ago as part of their combined clinical trial with phaco and excimer laser trabeculostomy, and am now a part of their standalone prospective clinical trial. So it's good to be back.
Yeah, good to see you guys again. And I'm excited to really dig into the part that as surgeons, we're always so excited about, because we think about it, we get excited, we're like, okay, this is going to be a great tool for the patients, but what does it actually require for me to do it? What we're talking about here is the Elios excimer laser trabeculostomy procedure, which involves there is a unit that will be in the OR, and that needs some calibration and setup. And then there's a small probe that you are that you are holding, and then you will position the patient to look into the angle. And then you'll use that small probe to create 10 ostia, about 200 microns in size, that are spread out throughout the portion of the angle that you can visualize. And typically that's going to be nasal if you're sitting temporally, as most of us are. And so there's a lot of little details that go into that. There'll be, first preparing the laser in order for it to be used during the procedure. How are you going to position the patient's head, and how do you get a good visualization of the angle? And then, what are you doing exactly as you're performing the procedure? So is there anything special you do differently or uniquely for this procedure?
I think it's very similar to all of our other MIGS procedures. With this one procedure, though, I do think that it is a little bit more important to ensure you have that en face view. And a large part of that is because of the bevel at the end of the probe. It hugs the angle so perfectly when you're en face. If you don't have that en face view, meaning if the patient's head isn't tilted properly and your microscope isn't tilted properly, where you're able to see the entire angle face, the probe itself may not hug the angle as well as we'd like it to. So this is one of those procedures where we really want to make sure we have proper positioning.
So Dan, what do you do? What's your procedure as you enter the room or prepare the patient for this procedure?
Thanks, Cathy. I think my biggest tip is actually before you enter the OR, or theatre as we call it in the UK. It's the difference between angle visualization at a slit lamp versus at an operating microscope. A slit lamp gonio, you can separate illumination from observing tower. But as soon as you're in theatre, you can't. So the angle is going to look different, and you need to just get used to how it looks in the OR. Mark's hit the nail on the head with the en face view, and that is often a lot more tilt than you ever think you need. It's a lot more patient's head rolling away from you, a lot of microscope canting or tilting the microscope towards you, and change the illumination. Most good cataract surgeons have microscope illumination, really quite dim for cataract surgery, and we rely on a lot of red reflex and not much direct illumination. So I have a different setting for MIGS devices whereby the illumination is 3 or 4 times greater. I go from 5% up to 50% sometimes, and my illumination is nearly always direct. I'm turning off the red reflex mode and wanting direct illumination so I can see into that angle. I don't want to see shadows around the corner. But yeah, getting those landmarks is key. So comparing your pre-op gonio on a slit lamp, and then you know roughly what you're going to find when you get in there for the theatre. And I've seen some other surgeons, and tried it myself, to use Vision Blue or Trypan Blue just to stain. So it doesn't need to be done. Most of us, could argue you don't need it. But if you're worried about landmarks, put some Trypan Blue in, wait 30 seconds, and it stains trabecular meshwork really nicely. So we all know that angles, when they're pigmented and stripy and they jump at us, are really easy, and others are just featureless, really. So that's when Trypan Blue can be your friend. So
that's great. Yeah. And I think that the other thing about, if depending on where you are in the procedure, because if you've got to the part of the procedure where maybe there was a lower intraocular pressure, that blood reflex into Schlemm's canal can do a similar thing and stain that, give you a nice, at least stripe where you know exactly where. And even if you raise the pressure after that and then evacuate some of the blood from Schlemm's, you've seen exactly where that is. And so I think that can be helpful. So, I mean, what I'm hearing from both of you is, visualization is so key. And I love the pearls that you gave on lighting. I think that's really important. I find that I also increase the magnification. So we're not often really high mag for our cataract surgery, but magnification can be your friend when you're in the angle, because you really get to distinguish those maybe more subtle features a little bit more easily with that. So for me, that's been something that's helpful. I think that what you mentioned as far as tilting the patient's head, you're going to tilt the patient's head away from you, the microscope towards you. And then I often have patients look away a little bit for fine tuning of that angle view so that we get the en-face view that Mark was describing. And it is so critical in these procedures. So a little bit more, let's dig into that a little bit more. We talked a little bit about the setup, and part of that is with this procedure that you have to calibrate the laser. So who does that, and when is that done in the whole scheme of things?
So in ROR, it's the technicians. They all get trained on how to calibrate the laser, and it's something that you have to do prior to each case. So it's not like our excimer laser that we have for LASIK, where we do our calibrations and it's good for the day. Every case that we do, we have to recalibrate, and it's calibrated with each probe. And so there is a little bit of a technique, because we are taking a sterile probe and we're having to insert a portion of it with its protective collar into the laser to calibrate that system for that patient. And so my technicians have always done this and had it ready before I entered the OR.
And Dan, is that about the same for you?
Yeah, true. So I'm definitely somebody who adds my MIGS to the end of the cataract procedure. I think there's advantages of that, and especially with Elios, where the device it's so precise. It checks the RFID of the probe, it checks the probe is transmitting, and it even checks the energy emitting from the end of the probe. And it won't let you proceed unless it's exactly happy. And it takes a couple of minutes, that step. But if it's happening whilst you're fakering, it doesn't matter. It adds nothing to the procedure. So I'm definitely let's do this at the end of the cataract procedure. Others argue doing it before, but I find that the phaco first means you've got the lens out, the angle's open. You've talked about how periods of low pressure and high pressure sort of almost suck back blood into Schlemm, so you get that landmark, which I think if you go straight into the eye and just do the laser, you might not see. And conversely, I like to have my patient with a slightly head down, feet up approach, again, trying to get some backflow into Schlemm's. But yeah, I find it's set up for me as soon as I've done my lenses in, the probe's in hand, and we're ready to go.
Yeah, and I think we should also just discuss the size of the laser, because when you hear excimer laser, you're thinking about your LASIK suite and how big it is. But the size of this device is just a little bit bigger than the CPU, and it's on wheels, and you can move it from OR to OR, and it doesn't really take up much space in your operating room. And so we're able to have our microscope, our phaco unit, the back table, and the laser unit all in one area, and it doesn't really take up much space. And I think it's important to to address, because again, when I hear excimer laser, I think this ginormous machine that we have to affix in one room and can't move it. This is a mobile unit similar to our phaco machines, but much smaller.
Yeah, I think it would fit in a carry-on.
Wheels.
Maybe not a European one, but an American one
Right.
for sure. So we talked about how important it is for visualization, and part of that is the fact that you need a gonio prism. Do you guys have a favorite gonio prism? What do you suggest especially for somebody getting started?
I quite like the disposable, single-use gonio prisms. You can left-handed and the right-handed version, and they are deliberately wide field. So some gonio prisms are about seeing the angle diametrically opposite you in great detail, but obviously with 10 shots to spread around, you want a wide angle view. I like being in control of it because I can adjust how much pressure I'm putting in the cornea or lack of pressure. I want this lens to float. I can roll it to the patient wherever their eye position is.
We have just about every kind of gonio prism at our surgical center because we have so many different surgeons, and there's even times that they hand me a left-handed prism, even though I'm right-handed, because it's all we have. But we have reusable, disposable. For this particular procedure, I do like the disposable because you do get a broader view of the angle, and it does help treat more of that nasal angle. But if you don't have the disposable, you can always rotate whatever prism you have, or even have the patient move their eye up or down a little bit to get a little bit broader view. So I don't really I think it just comes down to surgeon preference on what they want.
Yeah.
Totally agree. And now we've got a great view of the angle. Maybe we've stained it either with reflex blood or with trypan blue, both really good pearls. Are there other landmarks that are important when you're deciding exactly where to place the probe and then where to put your 10 microchannels?
So I think this is one of those things where you really have to understand the difference between a sample Lezy's line, pigmented TM, and the ciliary body. So you really want to understand your landmarks on gonioscopy. And it's not just for this procedure. It's for all MIGS. I've seen stents placed in the face of the ciliary body, large psychodialysis clefts, because surgeons thought they were in the pigmented TM, but they were in the face of the ciliary body. And this is no different because we are removing tissue. If we're not treating the pigmented TM, which is the TM overlying Schlemm's canal, and rather you're in the face of the ciliary body, you're going to get a significant amount of bleeding. And it's just because we're removing tissue, and as we're removing tissue, we're opening up blood vessels. And so it's very important to understand what the different levels of the angle are when you're performing this procedure. But with this probe, because of its diameter, it's almost like when we're implanting eye stents. You almost have to shoot a little bit more anterior to get your ostia a little bit more posterior. And so the probe itself is placed a little bit anterior to the pigmented TM, such that the posterior portion of the probe is at the level of the anterior-most portion of Schlemm's canal, or the anterior portion of the probe is right at about the level of Schwalbe's line, so that when the laser energy is delivered, you're going to get that ostia right in the middle of pigmented TM.
You've got three nodding heads here as you say that. So I think we've all come to that same conclusion along the way. And I think the kind of the buzzword that summarizes that is parallax, isn't it? So we're not shooting from angle across the AC to the diametrically opposite angle. You're coming down from above high. Your corneal incision is a high up landmark. You're coming down at that TM. So to hit something deeper, you've got to start above it if you're coming from higher up. So yeah, we all aim high to go low, and we're all getting that. So it's lovely to hear that across the pond, exactly the same thought process is happening.
I love that easy to remember thing though. Aim high to go low. I think that's great. And if our listeners, if you could keep that in mind, that if you're wondering like where exactly how do I get it just exactly placed, you are going to be a little higher than you think would be where you would just naturally put it.
I've recently changed what I do to try and get a greater angle of treatment. So I sit temporally on all my phacos, all my MIGS devices are in the nasal angle. But now we've got 10 shots rather than 2 or 3 devices or one big, snake device. We've got 10 shots to place. I started to feel, well, why are we trying to cram those into the nasal angle? So I now sit temporally, shoot 5 shots across the nasal angle, spin around to the top, go through my phaco side port, and then put 5 more inferiorly. So we know that most of Let's channels and drainage is inferonasal. So by spreading shots nasally and inferiorly with those 2 access points, I think I'm getting a greater effect. I don't know yet. It's too early to tell, but it makes logical sense. And the probe can go through a 1.2 millimeter side port incision quite happily. So it's no extra holes in the eyes. That my side port's already there waiting for me. So I started to do that.
Where do you typically place your side port in relationship to your main incision? If your main incision is at 0 or 180, I typically put mine 90 degrees away, but maybe you put yours just slightly closer to your main incision than that, or where are you placing it?
Yeah, so I'm left-handed but operate right-handed. But so side put the main incisions at pretty much at 20 or 200. I'm slightly off towards my right hand, and then I'm a bimanual irrigation aspirationer. So I've got naturally 2 side ports that sit at 90 and 270. So whichever eye I'm doing, I've always got a wound there ready to go, and I can get the probe through that small incision, and it's really watertight. But you find that even with a wide angle single use gonio prism, even if you've been as far inferior as you think you can go with that prism, when you sit at the top and shoot inferiorly, you can barely see that last shot. So you've got the entirety of that quadrant waiting to be treated. So I'm getting my 10 shots around, not quite 180 degrees, but probably 150 degrees I'm treating.
I love that, Pearl. That's a great idea, because it is a little bit, you're trying to get as far as you can, to the left or to the right, depending on which eye, that's superior, inferior. And I think that's one of the strengths here too, is that, because it is a small probe, we can, modify how it is that we want to treat. Maybe we have, for whatever reason, there's a reason to avoid a part of the angle that you don't want to be right there. And because we can, change where that access point is, gives us some flexibility in where we place those 10 fenestrations or those 10 ostia. So anything about how you hold the probe in your hand when you're going from one to the other? How do you determine, how far apart to place those different ostia?
So the probe itself has a little diamond on one area of the probe handle, and that guides you to understand where the bevel is. And so we want to place our finger on top of this little diamond, and that diamond will be directed vertically. And when the diamond's angle, or when the diamond is on the upper portion of the handle itself, our bevel is aligned with the angle. And so that's one of the little tips or training sessions that doctors will be aware of when they have the probe in their hand. But because of the diameter of the probe, when we instill our first channel, we want to move our probe over about the diameter of the probe itself. And so it's going to be about, I don't remember the exact diameter of the outer portion of the probe. But when you place your first spot, you move your probe over about 1 diameter of the probe. And then after you apply your second laser energy application, you move it over again another diameter, and so on and so forth.
So, and the same for you, Dan?
So I think it's clear to say straight off, the laser device will not let you do more than 10 channels. So you're limited to 10. So you're on license just doing 10 channels. You cannot try for an 11th. It won't allow you. But if I were to treat just from one access point, I would, as Mark said, make a channel, leave the same space again, and leave it. So it's on, off, and you're leaving the circular width of each probe width in the middle of each shot. Now I'm spreading them around. I've only done 2 cases so far spread, but I'm going to leave 1 channel, leave 2 spaces, 2 probe widths, and then go again. So basically doubling the width between them. But the probe is pretty flexible. It's just being keen just not to kind of tort it. It is quite flexible. So you just have to, like any MIGS device, just float around in there, not to try and talk the wound too much, talk with the Q, not talk with an LK. Just trying to be nice and neutral, and just think about your hand position. So if you're trying to reach too much and lift up or squash down your main incision, your clinical incision, you're going to burp or allow viscoelastic to come out, and that's when you have to refill. So if you are, wound neutral, as we call it when we're teaching it, just trying to really float and pivot through the wound, your viscoelastic stays in the eye, you maintain your view, and you keep your pressure, and you haven't got to refill. But often the surgeons who struggle with a view later on, 10 shots is a lot. By the 6th, 7th, 8th, they're losing their view. You're getting corneal striae. It's shallower. You've got some blood getting in the way, and that's because you've probably let the viscoelastic out. Either you're going to your hands pushing too hard, or you've burped some viscoelastic back out the eye. In which case, just stop, refill, relook, and start again. Don't just keep on going. It takes seconds to refill an eye with visco, and it makes your life so much easier.
I think some of it too is the angle at which we're entering the eye. Particularly with this probe, as Dan had mentioned, it is a little bit more flexible. So when you're in the eye, and the patient's view isn't where you want it to be, you can't use the probe to move the eye because it is a little flexible. Always try to stay in the center of the wound and angle yourself so that you're able to apply that first laser at the most extreme portion of the nasal angle that you can. And then as you're rotating along, maintaining the probe within the center of the wound, but using it as a fulcrum. And don't be afraid to reposition. There's nothing wrong with repositioning your seat, repositioning your scope, so that you can then go to the other extreme. I know personally for me, when I'm trying to go to the right, ergonomically, my hand has a little difficulty getting the last two spots in. So I just reposition my scope a little bit. I reposition myself in my chair, and then I'm able to get a much broader area. So don't be afraid to reposition.
Yeah, I think that the other thing is if you're going to reposition to get a better angle to see in the angle, better angle for your hand as well, that's a great opportunity to just repressurize the anterior chamber, sort of get the patient looking exactly where you want it, take a couple breaths on your first few cases so that, you're just able to do that just as accurately and straightforwardly as you did the beginning of the treatment as well. So anything that surprised you about doing this? Anything, misconceptions you had going into it, worries that you had, or even changes to technique that you've developed over time?
It's a very clean procedure, and I was introduced to it several years ago through a presentation, and I was excited about it. But just seeing how clean it was intra-op, and then seeing what patients look like post-op, it is commensurate to other, I'm going to call them smaller MIGS procedures, where it's almost as though we're just doing cataract surgery. But when you do see blood, it's one thing if I'm talking to refractive surgeons are sometimes afraid of a little bit of blood. But I always tell patients that when I see blood, I'm actually a little happy because it's confirmatory that their outflow system's intact. And yes, you may not get that great bang for your buck on post-op day one where they're 20/15, but a week later they'll get there, but they'll be off of their medication. So blood is not bad. Blood is something that is confirmatory that there's a direct communication between the anterior chamber and that distal outflow system.
Yeah. So Schlemm's canal, it's a vein, isn't it, really? So if you tap into the vein in your hand, you expect to see a drop of red stuff. It's the same idea. I echo your thoughts that it is so clean. I thought I would see blood reflex after every shot, but I really don't. You only seem to get the blood refluxing once you've dropped the pressure down below 10, 15. Then you get it as you're doing your irrigation at the end of the case. During the case, you don't get that blood back despite popping a hole into a blood-filled canal.
One thing that I think is really important to mention, though, is that I think there is going to be some question about the depth of the laser, because if you're applying laser treatment, you see blood, I think some surgeons will automatically say, well, we're damaging sclera. But the laser actually doesn't propagate beyond Schlemm's canal because of the fluid that's within the canal. So it's treating the proximal system through the inner wall of Schlemm's canal, but does not go beyond it. And so the blood we're seeing is not blood because we're going through sclera and we're getting bleeding from the sclera. It truly is a regurgitation of blood that's within the canal.
Mm-hmm. Yep. And if you get a little, then it's great to just go back in, reinflate the anterior chamber. And at the same time, you're really just flushing the blood away so that it's not blocking trabecular meshwork and impairing your view. And so you kind of have two reasons to put additional viscoelastic in there. But those are great pearls. Is this like anything else that you do? Is there something comparable as far as the complexity of this procedure? What would you equate it to?
Yeah, I think the skills you need for Elios are the same as any other transtrabecular MIGS. So there are some devices you are in. You are sliding a guide wire into Schlemms or a metallic thing down Schlemms. You'll see it go in. But there are others where you don't know you're there until you are reducing the pressure. But the same skills of good gonioscopy, good view, gentle floating with your hand, and then the kind of the celebration of seeing hopefully 10 tiny points of reflux at the end of the case. It's a great thing to see.
I think if I had to compare it to another MIGS device, I think everything from going from your chlorocorneal incision to the angles is very similar to the iStent Inject W platform. And it's you're transcending the anterior chamber, you're dimpling the TM just slightly, and instead of pressing a button down with your finger, you're applying the laser energy with your foot pedal, and then you're doing that 10 times. So I think the approach for people that are familiar with that the iStent platform, it's almost like doing that, but you're doing it 10 times.
I think one of the nice things is you're not pushing anything in your hand, because that always has the risk of actually moving the probe. And the fact that the way you deploy the energy is your foot is completely independent, and you can really stay steadier. And then I think there is a real advantage, especially I do have patients who ask me, are you leaving anything in the eye? And it's really kind of nice that we're doing this, having a great effect that's lasting and efficacious, but we're not leaving anything. And all we have is just normal tissue that's surrounding the area that we've impacted. So I think a lot of advantages that way as well. Thank you guys so much for sharing your pearls on how we actually do this treatment. And I'm really excited to get it in the hands of our colleagues.
Thank you for tuning into this episode of Interventional Glaucoma. Want to hear more? Be sure to click the subscribe button to be notified of new episodes. For more information about this episode's topic, read the show notes at eliosvision.com/podcast. Elios Vision GmbH is the EU distributor of Elios, manufactured by Emlaze GmbH, and the Fido laser applicator, manufactured by Vinert Fiber Optics GmbH. Elios is CE marked and licensed for use in the EU and is currently under investigational use in the US. Please refer to the full disclaimer in the show notes.